Hold on. Hola. This is Jerry Sampson at the Nathos Classroom in Atlanta, Georgia, USA. I'd like you to take just a few minutes to consider what Juan Roberto Lopez and I have planned for you July 11th and 12th, 2014 in Medellín, Colombia. What we have in mind is a mixed dentition, age-appropriate orthodontic course. This will emphasize hands-on mechanics and some wire bending. An unusual experience in that we will cover all kinds of mixed dentition treatment, including treatment for asymmetries, crowding, Class 2, and Class 3. Let's take a look at a few of the examples of cases that I'll be showing. This won't be all of the cases, but a few ideas so that you can have some good appetizing thoughts about the course. Ortho Nathos, Medellín, Colombia. Answer this question. Why should a parent select you to treat their child? Well, I think the answer is quite straightforward. The answer is your expertise in the mixed dentition. The course that we have in mind will focus specifically on mixed dentition treatment. The objectives of mixed dentition treatment are quite straightforward. Intercept and improve, not finish the case. Mixed dentition treatment objectives are very, very obvious in that we would like to intercept the problem and stop things from getting as bad as they can possibly be before orthodontic treatment is started. We will be covering the age-appropriate mixed dentition treatment objectives in that there are 4 key areas to consider. This will be part of the handout and the manual that you will receive. Let's take a look at some case examples that we have in mind July 11th and 12th, 2014 in Medellín. This is a limited attendance course, and the reason the course attendance will be limited is because what Juan Roberto Lopez and I have in mind is a significant amount of hands-on experience. For example, let's take a look at this case that we will be looking at in detail. Patient presents with an interesting facial asymmetry. If you look on the right, yes, you'll notice that. And the asymmetry becomes more obvious when she's biting on an instrument so that we can see that in fact there is a true posterior occlusal asymmetry. This picture is not taken at an angle. This is actually the asymmetry that this girl presents with. You'll notice that she has elements of a true right unilateral posterior crossbite. Notice that the primary canines, if you'll look at the cursor, are Class 1, not insignificant crossbite, but posterior to that there is a significant crossbite. The crossbite is not present on the left side, and the patient has a minimal centric slide. What would you be thinking about as far as treating this particular patient? What options exist? Here's the same patient 4.5 years after all orthodontic treatment. She is 21.5 years of age. Do you think that she shows acceptable facial aesthetic balance? If you look carefully, you will also notice the subtle facial asymmetry is still present. You can see this again on the frontal view on your left, as well as in the smile. Notice the orbital asymmetry. These are things that are not correctable, of course, orthodontically. But this girl shows very nice facial balance, and when smiling, good dental facial balance, good inclination of the upper incisors. She also shows quite an acceptable occlusion with a minimal midline deviation. In fact, when we look at the literature, many asymmetries are due to true mandibular skeletal asymmetries. Correcting these orthodontically is not possible, and we will look at the literature on that. Another thing that we'll be covering in detail is simplified correction of the mixed dentition with minimal effort and incisor alignment. This was achieved in 4 weeks, and then continuous arch wire was placed for 8 weeks total treatment. The middle picture was taken 4 weeks. That's the first visit after placement of the brackets and an initial very inexpensive segmental arch wire. So total treatment time from the upper left area to the lower right was 8 weeks. You'll be doing hands-on mechanics for this type of alignment. Another thing that we'll be talking about in the mixed dentition is crowding in the primary, mixed, and permanent dentitions. Extraction versus non-extraction versus the true borderline extraction decisions. For example, let's take a look at this particular patient. 7 years, 3 months of age. She presents from a frontal view. You can see that she looks rather full. And from profile, what would you expect to see when you look inside of her mouth? This is a case that we'll be looking at in substantial detail. Notice the full convexity and what one might consider a class 2 appearance. Note that she has significant crowding, a transitional open bite. However, surprisingly, her canines are class 1 in the mixed dentition. So note the class 1 canines, although a class 2 facial appearance. What will be the best way to approach a class 1 occlusion present in a class 2 facial skeleton? Also, significant crowding is present. Her cephalometrics show a dolichofacial pattern, significant class 2 convexity. The maxillomandibular difference that you'll notice right here is plus 7 millimeters. That's a significant discrepancy with her maxilla forward at 100 degrees and her mandible essentially normally related to cranial base at 90 degrees. How would you be thinking about treating this patient? Class 2 skeletal, class 1 dental, convex full facial appearance, significant dental crowding. Here is the same patient when she is 24 years of age. What decisions do you think were made for this patient? The actual treatment time in fixed appliances was very brief. Decisions were made during the early mixed dentition. Do you think she was treated extraction or non-extraction? Do you agree with her facial profile at 24 years of age? Extraction versus non-extraction. Smiling profile, note that the angulation of the upper incisors is in good balance with the face. Good dental facial balance. Another patient that we will be taking a look at is a series of patients who presents with this type of discrepancy. Here we have a 7.5-year-old girl. Frontal view, she shows reasonable symmetry, but in profile, she has quite a recessive profile. This is not the type of face that we would like to treat with extractions. However, when we look inside of her mouth, we see some significant considerations. We notice the frenum, also a fragile zone of attached tissue at the lower incisors. Note the rather significant mandibular midline shift to the patient's left. On the right side, she shows right canines are class 1. Right primary canines are class 1 in the mixed dentition, but she has significant crowding at the lower left permanent cuspid. Also note the midline deviation and the significant area of fragile zone of attached tissue. What would you be thinking about for this particular patient? Do you think she's an extraction case, a non-extraction case? Do you think she'll need a frenectomy? Do you think that she will need a soft tissue graft. Panoramic view, interestingly, she has very pegged laterals with absolutely no root formation. You'll note the significantly blocked canine at the lower left side. What are you thinking about for this patient? Perhaps extract the upper laterals and a lower left permanent lateral. Substitute the canines. Well, one of the canines is reasonable in its vertical position, but the other canine is quite mesial angular, a sign of potential ectopic eruption. What thoughts are going through your mind as far as treatment options? Perhaps you are thinking about taking out the lower right primary cuspid right here. What's been your experience of taking out the lower right deciduous cuspid and then hoping for a midline shift to the right? That is a technique that I have never found to be very productive. Notice the very significant mandibular asymmetry in the anterior region. How would you go from this result from here to here, from pre-treatment to the same patient after the permanent canine is in, using very, very simplified and smart mechanics, something that you will actually be doing with hands-on? You will see a number of these particular patients, and the use of simplified hands-on mechanics for the maxillary and mandibular arches. One of our goals would be stability in the permanent dentition. This is the same patient 9 years post-treatment. You'll notice a nice right side class 1 canine. You'll also note that the permanent laterals have been built up. The peg laterals have had some bonding. It's interesting from a frontal view that she never had a frenectomy, nor did she require a graft. I think we see an adequate zone of attached tissue. How do you think that this result was achieved with minimal effort in the first phase? This is a very short treatment time in the first phase. Here is her facial balance 9 years post-treatment. Quite an acceptable facial balance, treated in 2 phases. First, the most important phase in the mixed dentition. You will be seeing a number of these particular patients, including with hands-on mechanics. Another patient that we will be looking at is this type of patient. As mentioned, these are not all the patients that you'll be seeing, but a representative example to pique your interest. Here we have a patient who's nearly 9 years of age. Nice facial balance from a frontal view. However, in profile he looks full enough. Would you like to see him look more full? One of the considerations in the mixed dentition for this particular patient: upright upper incisors, significant lower arch crowding, right unilateral posterior crossbite, bilateral apparent class 1 canines, very tapered upper and lower arches, and you'll notice that the upper right first permanent molar is rotated and displaced to the palatal side. Significant dental crowding is present. What are you thinking about for this particular patient? He presents with a mesofacial pattern and very upright upper and lower incisors. What treatment options would you be considering for this patient? You'll find that Juan Roberto Lopez and I will emphasize treatment options in our thought processes. This makes things much less confusing. So what treatment options are you considering? Not the treatment plan, the treatment options. Here's the patient 3 years and 10 months later. He's had minimal first phase treatment. Do you agree with his facial balance on the right side? I think he has quite nice facial balance. Here he is 1 year and 9 months post-all treatment, do you think he was treated extraction or non-extraction? The first question is do you like his facial balance? Do you like his dental facial balance when smiling? Here's a series of progress pictures. How do you think that this result was achieved? How were these decisions made? Was this extraction or non-extraction? This case will be covered in significant detail along with other extraction versus non-extraction patients. How were the decisions made? What mechanics were done? This patient is 8 years and 2 months of age. What do you think you'll see when you look inside of his mouth? Convex profile, mentalis strain. You'll notice a lot of strain in his chin. He evidently does not keep his lips together at rest and presents with a type 1 open bite. As you'll recall from the work of Moyers, there are 3 types of open bite. Type 1 or simple, type 2 also called a compound open bite, and type 3 a complex open bite. This patient presents with a type 1 class 2 open bite. Certainly the crowding in this particular patient wouldn't even consider warranting the immediate need for extractions. The main reason that I consider extractions of permanent teeth is crowding. Here we see a full class 2 open bite patient. Cephalometrically, what do you think are the most important things as far as long-term stability? Facial pattern would be considered one of the single most important things. The angulation of the upper and lower incisors. The distance of the incisors from the functional occlusal plane. What options are you considering for this patient? What treatment sequence would you consider to be best? One of the most important things that we'll be looking at in this hands-on mixed dentition course in Medellín are the factors for open bite. Certainly one of the most frightening things that we treat on a daily basis are open bites. How to go from an open bite to a closed bite with no patient cooperation and very simplified mechanics. You will be engaged in actually doing the hands-on mechanics. There is nothing new for you to purchase. You have everything you need in your office. The limited attendance course will emphasize hands-on, and you will be receiving a supply list of pliers that you should be bringing to the course for the hands-on wire bending exercises. How stable do you think this particular case would be? Here he is 2 years post all orthodontic treatment. He is not wearing fixed retainers. He in fact is wearing removable retainers, and he only wears these a few nights a week. Treated non-extraction, a reasonable end result, treated in 2 phases. The second phase of comprehensive orthodontics was very, very short. The first phase involved minimal patient compliance as far as the open bite. Another case example is this patient, 9 years, 5 months of age, an obvious brachyfacial pattern, very straight profile for a boy this age. What are you thinking about for this patient? Initial impression, he has a substantial diastema, very low slung frenum. And what initial impressions do you have for this patient? Aha! As you might have suspected, he is congenitally missing both upper laterals, his severely mesial angular canines. Full class 2 posterior dentition, but certainly a case that warrants a lot of thought. Are you thinking about finishing in class 2? Are you thinking about canine substitution? Are you thinking about the options for bringing the canines back? If so, then the first phase of treatment would need to involve some sort of Class 2 mechanics. This patient is Class 1 skeletal brachyfacial pattern, but Class 2 dental in the posterior area. What treatment options would be best? Consider implants, consider canine substitution. What complications are we now seeing with implants? What's the best time to do an implant? Options: finish Class 2 and substitute the canines, finish Class 1 and use implants. What type of informed consent should we have from the parents? What options would you be looking at if this were, for example, your nephew or your son? Options that we will be discussing for this rather interesting case involve the problematic movement of the center of resistance of the canines. You'll be exposed to the details of mechanics. For example, if the canine erupts mesial angular, as we see here, moving the center of resistance back into Class 1 and moving the canine upright, that's not too difficult orthodontically. However, the posterior occlusion would need to be Class 1 in order to do that. If, however, I need to translate the canine backwards and move it around the corner of the arch and get the cortical plate to remodel, this is very challenging orthodontically. Another option would be for movement of the center of resistance, and anytime I have to translate forward or backward, this presents a significant challenge because of the size of the root, cortical plate remodeling, and the distance of the force systems to the center of resistance. Or perhaps one is considered in other patients moving all of the posterior forward and finishing Class 2 when congenitally missing a lateral incisor. These are things we will be discussing in detail, hands-on mechanics, for our course 2014, July 11th and 12th in Medellín, Colombia. This is Juan Roberto Lopez's email address. This is a limited attendance course taught by me and Juan Roberto in Medellín, Colombia. Check your schedule. It's best to sign up early. Hands-on mechanics, hands-on exercise will be emphasized. If you have questions, contact Juan Roberto Lopez in Medellín at this email address.
Well, there you have it. July 11th and 12th, 2014 in Medellín, Colombia. In addition to the hands-on experience, people who attend the course will be receiving an access code for the Nathos website. There will be a detailed review of many of the cases that we will be showing to you on July 11th and 12th. If you have questions, please contact Juan Roberto Lopez. I'll look forward to seeing you in Medellín. Ciao.